Hello, everyone. Welcome to the Vanderbilt University Medical Center's FACETS Geriatric Curriculum video series. We are joined today by Dr. Mara Duggan, who's the Program Director and Inpatient ACE Unit Geriatrician, Mallory Bryant, an intern here in the Vanderbilt Medicine Department, and myself, Thomas Horton, who's a third-year medicine resident as well. So today we're going to be talking about frailty and kind of everything that encompasses that term. I must admit, Dr. Duggan, that before I was on the geriatrics rotation in the ACE unit, I had no idea what frailty was. Is this something that you hear from a lot of trainees and learners?
Absolutely. So this is a topic in our curriculum. I usually start out with what is frailty? And the learners that had not watched any of our content ahead of time or reviewed the booklet ahead of time have no idea, right? They're just they will say increased vulnerability. And that is one of the most important aspects of frailty. But if asked how to diagnose it, most of them could not. If asked what are the 5 features of this phenotype, most of them could not. Many of them say, you just know it when you see it. And so they use their gut to assess that.
Yeah, that's fair. And how do you, I would say, what's the terminology that you use when you're kind of instructing learners on this topic?
Yeah, so frailty is a phenotype. It's a clinical syndrome that we see where people have, as you age, you have increased vulnerability, and sort of on that spectrum is frailty, which includes physical weakness, slowness, a low level of physical activity, fatigue or exhaustion, and unintentional weight loss. And so that's what was described originally by Freed as the frailty phenotype. And we also know that multimorbidity contributes to frailty. There are other camps of frailty research that approach frailty with more of a cumulative deficit model, where for every abnormal lab value and medical problem and physical issue, you sort of on this frailty score. And so there are frailty indices. There are sort of clinical screening tools to assess for the frailty phenotype. And in the end, we're really, I think, getting at the same thing here, which is this person developing this syndrome of frailty who is at increased risk of developing harm, often from the healthcare system itself, and is more vulnerable to disease and mortality and negative outcomes.
That's really helpful. And when you're thinking about frailty or patients with this phenotype, is this something that you can, assign while they're inpatient with maybe an acute illness, or is it something that you would do more in the outpatient setting, or maybe a little bit of both?
Yeah, that's a great question. I don't know of any frailty screening tools that were developed for acute care, right? For somebody who's acutely ill. We use frailty screening tools in the inpatient setting. But if, for example, if we're assessing for fatigue, right, exhaustion, we don't ask, are you exhausted now with your pneumonia and sepsis, right? We ask, over the past few months, are you more fatigued than not? You more often fatigued than not. And so, it's similar to the review of systems. You're sort of looking further back on what a person's baseline is. And so we do use these tools in the inpatient setting. And I think the important thing is, aside from what's acutely going on and the changes that have led to the current illness, do we think this person at baseline is frail?
That's great. Yeah, and some things that, it's difficult to discern sometimes, whether they're like this in the inpatient, because sometimes in the ACE unit, you just have that snapshot and it's difficult to get that corollary information, at least on the admission side in the history and physical. So that's really helpful to kind of to see. And let's say that we're trying to assign this phenotype, as I mentioned, what sort of, are there any Vanderbilt kind of approved scales that we use, or one that you like to utilize?
Yeah, absolutely. So again, there's tons of scales and tools out there. I really like the Frail scale. Um, it's been validated. It's quick and dirty, pretty easy to do. And it really gets at the functioning of your patient. So it actually is really easy because it has Frail, abbreviating the 5 features that you're looking for. And it's pretty quick to do. So you ask patients, are you fatigued more often than not? Can you climb? That's the F, fatigue. R is for resistance. Can you climb a flight of stairs? A is aerobic. Can you walk a block? I is, do you have more than 5 chronic illnesses? L is, have you lost weight? And specifically, have you lost more than 5% of your weight in the past 6 months? And so these are 5 pretty easy questions to get at. You might have to do some math, asking people how much weight they've lost in 6 months, and then figure out if it's 5% or not. And when they validated the tool, they considered 1 or 2 of 5 to be pre-frail, and 3 or more out of 5 to be frail. And so for me, clinically, it's a quick and dirty way to get a sense of, do they have frailty at baseline? Or is it likely that they have frailty at baseline? And do I need to factor that into figuring out whether this patient is going to be at increased risk after a surgery, for example? So that's sort of the way that I like to use it, and that we train our learners to use it. There are other scales out there within the Vanderbilt EPIC system. The clinical frailty scale is also there. It's sort of a scale from 1 to 9, going from very fit to terminally ill. And it's based off of your observation of the patient and sort of their functional status. I find it clinically to be a little bit less helpful than the scale.
Interesting. And when these patients are, have the frailty, terminology assigned to them, or diagnosis, what does that mean for them? Like, moving forward, what can you expect in their long-term prognosis, or even how do we treat frailty if we can?
Yeah. So the whole buzz in the research world, from what I hear, is about preventing frailty and looking earlier, but before one has developed frailty. It's kind of similar to dementia. Like, once you have developed dementia, it's too late to, the cat's out of the bag.
Absolutely.
Horses out of the race, whatever that saying is. And so looking earlier at people who are not frail or who are pre-frail, and how can we help those people to try to reverse this frailty cycle? There are some data on rehabilitation, right? So rehab before, say, a surgery, and nutritional supplementation that have shown improvements in some of these frailty measures. In terms of once you've already developed frailty, you can try things like rehabilitation and nutrition. I don't know that there is strong evidence that helps. I think clinically for us, the most useful sort of the best utility of these frailty screens is for counseling patients. So telling them, they may not have many medical problems, right? They may be very healthy and living independently, and they had a fall and now they've been in bed and they're much weaker and they have to go to a nursing home. It's recommended for them to go to a nursing home for rehab, and they sort of don't understand, like, but I was totally fine before this happened. And you have to tell them, well, you had this syndrome called frailty, and it makes you more at risk for having problems like falls and injury. And so we need to work as hard as we can to support you in this, course of illness that you have. So I think patient education is one big thing where it's helpful. And the second would be risk stratification and prognostication. So if you have a patient that's frail, they're more likely to have postoperative complications after a surgery, after a major surgery. And it can be helpful for you as you think about a patient with maybe a life-limiting illness versus life-limiting illness plus frailty, right? They're going to be at a higher risk of mortality. And so I think just in terms of counseling patients, determining a sort of a prognosis, factoring in that frailty, and communicating that prognosis, as well as communicating with our surgical colleagues, that can be very helpful.
That's right. I think I have done a poor job, and something I want to improve on moving forward is actually identifying these patients who are in the pre-frailty stage on the inpatient setting, to where we can kind of optimize them as they transition care to their outpatient provider, whether it's their primary care or geriatrician, to say, hey, we're concerned about this. Just like you said, that's like the target of where we can, hopefully prevent this from happening. So moving forward, I really want to make that, a big part of my practice with every patient that comes into the ACE unit.
Absolutely. I think recognizing it, using a validated screening tool is ideal, right? Because what most residents do that I've worked with is tell me, this is a 90-year-old lady who's frail and she's here with XYZ. They didn't do the frailty scale on them. They just looked at the bed. Somebody's laying in bed and they have a hospital gown on and they just say they're frail, right? Dr. Colleen Christmas from Hopkins taught me that the hospital gown actually adds 10 years, right? And so
Like
if you
that.
saw them,
Yeah.
if you saw them just like in the clinic, the same person, same functional status and everything, you would think they were, younger than you would think they were in the hospital. And so you can't just go off of what somebody looks like. You really have to assess them. And that's where these validated screening tools can be really helpful.
That's great. Mallory, have you encountered a lot of patients who actually had the designation of frailty during your year?
I'm not sure I've encountered very many who had like a formal diagnosis of frailty. I think I see a lot of people use like cachectic and frail interchangeably as like part of their physical exam, almost more than like a medical diagnosis, like in the one-liner.
Yeah, that's a great point. You'll see, just like Dr. Duggan was saying, 75-year-old frail appearing gentleman. And that is tough to kind of delineate, and then kind of pervasive throughout all specialties of medicine, I think.
I would say the other important thing is when patients get assumed they're frail, and in fact they're not. I've had to have really in-depth conversations and sort of education. I've had to educate surgeons on, this patient's too old to operate, they're too frail is the message I get, right? And from my perspective, they're independent in their ADLs and IADLs. They screen negative for frailty or pre-frailty, and their goal is to live as long as possible. So those cases are very black and white to me in terms of, if there's an indication for surgery, I think at least it should be discussed with the patient instead of just saying she's not a surgical candidate at all. And obviously I'm not a surgeon. I know these are very nuanced decisions, but that is something that I often see. And oftentimes it's frailty. Oftentimes it's just ageism, right? Like they're just too old. I'm not going to operate on them. Whereas if there was a younger person that had the same functional status, it'd be a no-brainer. So I think that is the way to think about it.
Definitely great things to think about. Well, Dr. Duggan, this has been extremely helpful in kind of parsing out some of the nebulous nature of what frailty means to our learners. Are there any kind of key points or pearls that you want the learners to take away with?
Yeah, I think just not labeling people as frail before you actually assess them and screen them. And practicing that screening, practicing recognizing frailty, practice counseling patients on what frailty might mean for them, and sort of explaining it in a very basic way as your body is not as strong as it used to be. And so it takes you longer to recover. And sometimes you don't recover, right? So that they have a little bit of expectation of what is to come or what might be to come, so that when those events happen, they're not so blindsided, and maybe they've had a chance to prepare and do some advanced care planning. and, work out some arrangements with their family, funeral arrangements and things like that, that are helpful for families and for patients to do while they're still alive and cognitively intact.
Definitely. Well, thank you so much. And we thank you all for listening and watching. This is another FACETS curriculum video, and we look forward to educating you on the various ACE unit and geriatric syndromes moving forward. Thanks.